with Operation Smile Ghana and a member of the Pediatric Society of Ghana. He is an enthusiastic people's person. He has a keen interest in pediatric intensive care, pediatric emergency, and neonatology. Kindly help me welcome Dr. Edeb Wilson Saba. Dr. Saba, your guest, your presenter. Thank you.
Thank you, Gifty. That was a very extensive introduction. I didn't know I had all that. Thank you so much. But you forgot to add that I'm an honorary staff of the whole teaching hospital.
Of course, yes. An associate.
Okay, so overview of prematurity. This afternoon, my objective is for us to know the etiology of preterm birth, know the various classifications of prematurity, to know some of the common complications of prematurity, and then to manage some of the common complications of prematurity, especially with emphasis on skin-to-skin care for each child. This is my outline. So the normal duration of pregnancy in a human female is about 280 days. That's 40 weeks. And by WHO definition, if a baby is born alive before 37 weeks of pregnancy is completed or are completed, then that is a preterm. Last year or last 2 years when I had to do this slide, the estimated babies that were born too early, that was in 2018, was 15 million. The number has reduced to 13.4 million babies in 2020, and that's about 1 in 10 babies that are born too early. If you look at the preterm complications, it's a leading cause of death among children under 5 years of age, and is responsible for about 900,000 deaths in 2019 alone. Across countries, if you look at different countries, the rate of preterm birth ranges from 4 to 16% of babies born in 2020. About 60% of preterms are delivered in Southern Asia and Sub-Saharan Africa, but the global impact is still significant. It's not just those two areas. Survival rate differs for extremely preterm babies based on the income level of the country they are born in. So if you are born in a low income countries, over 90% of those who are extremely preterm or those who are born around 28 weeks will die within days, whilst in high income settings, only about 10% of them will die. Majority of them will survive. Now, if you survive, preterms face a lifetime of disability, including learning disability, visual and hearing problems. And I'm sure the rest of my co-facilitators would talk about the long-term follow-up and why we need to follow them up. A study done in Kwalibu Teaching Hospital and estimated that the average length of stay for preterms on admission in regional hospitals and district hospitals ranges from 14 to 19 days. And this is actually based on the facility that they are admitted to. In regional hospitals, they tend to stay longer, about 19 days. And then in district hospital, they tend to stay up to 14 days. The preterm is capital intensive. It's capital intensive in that from that same study, it showed that the cost of paying, even with national health insurance, you should estimate between $27 to $332 for your stay in the hospital. It goes as high as $1,200 or $1,200 for those who have multiple gestations. And if you consider where the dollar is right now, you can do the calculation in your head and see how much it costs to take care of one. And this out of pocket is what the parents pay, not what health insurance covers. Now let's look at classification of preterms. There are subcategories of preterm bed based on their gestational age. So extremely preterm, less than 28 weeks, very preterm, 28 weeks to 32 weeks, and moderate to late preterm, 32 to 37 weeks. This WHO classification. If you use the weight, less than 2,500 grams is low birth weight, less than 1,500 grams, very low birth weight, and less than 1,000 grams, extreme low birth weight. Now, what causes prematurity? It can be grouped into maternal causes, uterine causes, fetal causes, and others. For maternal causes, you are talking about malnutrition, anemia, teenage pregnancy, multiparity, multiple gestation, preeclampsia. If the mother has chronic illnesses like diabetes, renal disease, heart disease, hypertension, if there's an infection, so malaria, urinary tract infections, chorioamnionitis, where an infection goes to ascend into the uterus. Lower socioeconomic status, smoking, and alcohol use are some of the maternal causes. For uterine causes, you're looking at bicondylitis uterus, an incompetent cervix, if there is placenta previa, abruptio placenta, and placental dysfunction. For the fetus itself to cause preterm birth, you need fetal distress, and I'm sure the midwives on this Zoom meeting would know, who understand fetal distress better than any of us. Multiple gestation, if there are chromosomal abnormalities or disorders, intrauterine infections, erythroblastosis, non-immune hydrops, all these are fetal causes of preterm birth. Others are polyhydramnios. If there's trauma, we are in a world where road traffic accidents are quite common, domestic violence are quite common. You have premature rupture of membranes or iatrogenic, where you need to perform a procedure on the mother and therefore end up inducing preterm birth. There are some associated factors, like, even though low socioeconomic status, like I said, maternal malnutrition, teenage pregnancy, if you have close spacing of your pregnancies, domestic violence, as I said earlier, physical, sexual, or even emotional abuse. There's lack of social support, stress, long working hours. So for our younger colleagues our junior colleagues who are pregnant, we need to have a look at the long working hours that they have to endure, long periods of standing, if you want to prevent them from getting preterm births. Complications of preterm, there is the immediate and then there's the long-term complications. Immediate, think of hypothermia, hypoglycemia, hypocalcemia, respiratory difficulties, feeding problems, neonatal jaundice, increased susceptibility to infections, hepatizing enterocolitis, patent ductus arteriosus, anemia, intraventricular hemorrhage, metabolic bone disease. It's not limited to this and others. Long-term complications, chronic lung disease, poor growth, cerebral palsy, post-hemorrhagic hydrocephalus, learning problems, deafness, visual problems, that's retinopathy of prematurity, which will be discussed later on by my co-facilitator. Now let's have a look at management of the preterm. It's a multidisciplinary approach. It involves all of us, all stakeholders, midwives, doctors, pediatricians, neonatologists, specialist nurses, regular nurses, physiotherapists, occupational therapists, psychologists, etc., support groups, all form part of it. And the main aim is to have proper anticipation and prevention off the complications. Remember that the preterm comes out not because they are, in most cases, are not ill. They just came too early. So you need to anticipate and prevent their complications, and then they will be able to survive. Management starts directly from the delivery room or the labor ward. So every delivery should be attended to by a skilled birth attendant. So someone who has been trained to conduct a delivery or to catch a baby. There should be proper resuscitation at birth, early stabilization of vital signs, prevention of hypothermia and hypoglycemia in the delivery room. Has been shown to be related with good outcomes with minimal complications. I'm sure we've all seen these posters hanging in our labor wards and our NICUs. So they're helping babies breathe and the essential care for small babies. What is we usually find on our wards are the essential care for every baby, but there's particular one for the preterm. And this is to help us to remember what to do for the preterm when in our labor wards and maternities. Now, after the baby has been delivered, always maintain a thermoneutral environment. Those are your principles of management. And maintain a thermoneutral environment. Maintain fluid and electrolyte balance. Give oxygen as needed. And then feed. Now, when you are once you start feeding, start thinking of supplementation with iron and vitamins, protection from infection, and then look out for the complications of the prematurity. And always consider the immaturity of the liver and kidneys to metabolize drugs, so you do not overwhelm them with drugs. Now, when it comes to the thermal control, there's a use of incubators or radiant warmers in facilities where these are available. But if they are not available, especially in the district setting, use of bulbs over the baby's cot will provide warmth. Now, if this child is in transit, you are referring to a secondary facility or tertiary facility. To provide warmth, you can wrap this child in plastic polythene bag or a foil, or move the child skin to skin with the mother, so you can maintain the infant's core temperature at 36.5 to 37.4 degrees Celsius. The humidity should always be maintained at 40 to 60%, and then have an appropriate nursery environment. Always continue to monitor the infant's temperature. Temperature. Now, one of the things that we use to help with the infant's temperature is the kangaroo mother care, and this, or what we all call KMC. Recently, I've been told to stop calling it KMC and call it KC, because it is not only the mother that we use for it, but I prefer the KMC so we can all remember what it entails. Kangaroo position, which is the skin-to-skin contact. Mother and M for mother and milk, because you need to do exclusive breastfeeding. And C for care and support for the mother and the baby.
Hello, sorry. It seems we
Good afternoon, everyone.
have
It
lost
seems we have lost
Dr.
Dr. Saba. Once again, you are welcome to our CPG program, the Whole Teaching Hospital, Pediatric and Sub-BMC, in collaboration of the Pediatric Society of Ghana, is hosting this CPG under the theme Safe Care or Preterm Everywhere, as part of our Prematurity Week celebration, which is also under the theme Small Actions, Big Impact. You are all welcome. We look forward to your cooperation. If you have questions, kindly put them in the chat box. At the right time, we would avail some time for you for your questions to be answered. Thank you very much. It seems we have Dr. Saba back. Hello. Dr. Saba. Hello, Dr. Alofi.
Yes, Dr. Gifty. Yes. So, sorry, we have lost Dr. Saba. Once he logs back on, we would continue from where he left off. Sorry for the inconvenience, please. We would want to move on to the next presentation so that we don't waste time. Our next presentation is going to be on retinopathy of prematurity, the importance of screening and management.
Hello,
So
Dr. Saba.
Dr. Saba,
Dr.
yes.
Saba is back.
Dr. Saba is trying to.
Yes.
Yes, so we will take
Yes, sorry for network issues. I always say in Africa, you can't have a Zoom meeting without technical issues. So, okay, so I'll continue. So like I said, components of KMC involves a supportive environment, kangaroo position, nutrition, and discharge and follow-up. But then you need the support of the healthcare facility, with the staff in the hospital, the family will support in terms of discharge and follow-up, so the support the mother will receive at home. And those are the components of kangaroo mother care. Okay, so now let's look at feeding. Now for a healthy preterm or a small unit may be fed by either an NG tube, cup and spoon feeding, or directly from the breast. And the method of feeding each preterm or low birth weight infant has to be individualized. When you look at NG tube, it is for those who are smaller or less vigorous infants. Those who are not well-developed, who do not have a well-developed sucking reflex. And when you pass the tube can be in place for 3 to 7 days. It should be replaced by another tube through the alternate nostril. Through the alternate nostril, and then gradually change to cup or breastfeeding. As you increase the volume of feed, you decrease the IV fluids and do express breast milk. Now, if you are doing feeding by breast or cup, you must establish this before discharge. So the child does not go home with an NG tube. Must establish that feeding is by breast or by cup before the child goes home. And always attempt feeding by breast or cup or oral feeding for infants who are well, who are making sucking movements. They are not in distress. There's no vomiting or emesis, no abdominal distension. And if they weigh more than 1,500 or more, we can put to breast. And then sometimes we talk we top up with express breast milk as well. Now, how do we prevent sorry, I'd be muted. Prevent use of tocolytics, beta mimetics, prostaglandin inhibitors, and calcium channel blockers can also be used when the mother goes into labor to extend the stay of the preterm in the mother's womb. Now, another thing that we would need to emphasize is that antenatal clinic attendance should be encouraged, and all mothers should receive comprehensive, focused antenatal care. Then prevent maternal infections, because like I said earlier, maternal infections, urinary tract infections, malaria, chorioamnionitis predisposes to preterm death as well. So, summary. When I got to this slide, I was wondering what I needed to summarize on the slides, and I remembered that all that I've said goes with the theme for this year's World Prematurity Day. Small actions, big impact. The little things that we do goes a long way to make a big impact in the survival of these children. If you leave this CPD and not remember anything, remember that immediate skin-to-skin care for every baby everywhere goes a long way to save the newborn, both preterm or term, and increase their chances of survival. We are all partners in making our little ones survive. Thank you very much.
Thank you very much, Dr. Edith Saba. Like I said earlier, this CPD promised to be a very interesting and educative one. We would move on to take our next presentation, and I hand over to you, Dr. Aluti, to introduce to us the next presenter.
Yes, thank you, Dr. Gifty. So our next presenter is going to present on the topic retinopathy of prematurity, importance of screening and management. Our presenter is in the person of Dr. Med Brahima Imoro. So I'll give you a little bit of a background so we know our presenter. So Dr. Imoro Zeba is an ophthalmologist with the with subspecialty in vitreoretinal surgery. He's currently working at the Kolebu Teaching Hospital, where his clinical work is focused mainly in retinopathy of prematurity, sickle cell retinopathy, among others. He's also a senior lecturer with the Department of Surgery at GMS. His research interests are in the preservation of sight and reduction in visual impairment and blindness from retinal diseases. And his current research is on retinopathy of prematurity. He's a fellow of the Ghana and West Africa College of Surgeons, and he earned a fellowship in vitreoretinal surgery from LV Prasad Eye Institute in India. He's married with 3 children and is a fierce advocate for the topic we are about to discuss. So, Dr. Imoro, please, you have the floor. Thank you.
Thank you very much.
Thank you.
Dr. Imoro, sorry to interrupt you. We have our chairperson who has been introduced earlier joining us, Dr. Nanaya. Dr. Nanaya, we will give you some few minutes to give us a word before we continue. Thank you. Dr. Adria.
Hello.
Hello. You are welcome.
Hi. Thank you very much.
Can you please give us a few words before we continue with our presentation?
Okay. Hello, everyone. Welcome to today's program on prematurity. As we all know, as modern medicine becomes more developed, the survival of premature babies they survive more, which is a good thing. However, on the other side, it means that we're going to be faced with the complications that they are faced with, which will be the ones that we encounter earlier and much later. And so we all understand why it's important to have these discussions every now and then. And we are glad that we have it as a topic this year as well. So welcome, everyone. We are happy to have you all here. Everyone presenting and everyone listening, you're all very important because we'll take this and go out there and make a difference in their life. So thank you. And as you know, we'll hope to close before 6 p.m., but we hope that you'll be more interactive and not just listen. We will welcome all your questions. So welcome, and we may proceed.
Thank you, Chairperson. Dr. Med Imoro, please, you have the floor now. Thank you.
All right, thank you. And first of all, would like to thank the organizers for inviting me to talk on retinopathy of prematurity, which is something I've been advocating for screening of preterm babies since 2018. Am I audible? Is it clear? Can you hear me?
Yes, you are clear.
Yes, please.
Yes. All right, thank you. So even before I delve into the topic of retinopathy of prematurity, there are 2 pictures, one on the left side of the slide, in which the eye has been opened with a speculum, and you can see something white in the pupillary area. This is somebody who has presented with stage 5 retinopathy of prematurity. And so whatever intervention that is done, this child is going to remain blind for the rest of his or her life. And this was a baby I saw in March this year, who was referred from another teaching facility hospital to Kolebu Teaching Hospital. And yet these things are so avoidable if we institute very simple measures. And so you have this picture on the right side here, which was taken sometime in 2018, where I was examining a baby at the NICU of Kolebu Teaching Hospital. And it says, I'm premature, please test my eyes before 30 days. And this second picture is something that I want all of us to remember, that despite the increase in awareness of the Prematurity of Prematurity program in Kolebu Teaching Hospital, we receive referrals from pediatricians from other hospitals, and the babies, they get to the eye clinic at about 3 months of age or 4 months of age. If any baby has severe retinopathy of prematurity, by 3 months or 4 months, that baby's retina would have detached. So we want to place emphasis on the fact that if you have a preterm baby and you want the baby's eye to be screened for retinopathy of prematurity, it should be around 4 weeks to maximum 6 weeks. The baby should be seen within that period. Now, retinopathy of prematurity is a disorder of the immature retina. So with the immature retina in a preterm baby, usually the vessels or the retina is not fully vascularized. And so the avascular retina is where the problem occurs. And it's a leading cause of childhood blindness in high-income countries. Low and middle-income countries are not left out in this particular problem because it's also emerging as a cause of blindness as we have advances in neonatal care. So early detection and treatment of severe retinopathy of prematurity, which the technical people will call it type 1 retinopathy of prematurity, is key in preventing blindness. So we know that in sub-Saharan Africa, neonatal mortality rate is on the decline. And so there's improved survival. And so we have a lot more preterm babies surviving. And so it is not surprising that we are seeing a lot more babies blind from retinopathy of prematurity in Kolebu Teaching Hospital. Sometime in 2015, Akosua and team and her colleagues, they did a retrospective study at the Kolebu Teaching Hospital. And they noted that of the preterm babies who were admitted during the period of the retrospective review, 88% survived to discharge, 50% received oxygen. And the key thing about oxygen is you need to monitor oxygen. There should be judicious use of the oxygen that we give to these preterm babies. And yet there was lack of monitoring of oxygen in these babies. Certainly there was no documentation of monitoring. And they noticed that more than half of these babies fell within the screening criteria for retinopathy of prematurity. Now, how does retinopathy of prematurity occur? You have a preterm baby, and when the baby is born, the vessels would not have grown to involve the entire retina. That's up to the periphery. So you have a large zone of avascular retina. Now, the level of oxygen in the womb is lower than outside. So preterm babies born, they are exposed to high levels of oxygen. And this results in a reduction in vascular endothelial growth factor. But then there's some form of injury occurring, and so there's increase in reactive oxygen species. The high level of oxygen leads to vasoconstriction of the vessels. And so there's less supply of oxygen at some point to the neural tissues in the retina, despite the high exposure of the baby to oxygen. As for the neural elements in the retina, they continue to grow despite all this happening. So eventually, when you take off the oxygen, you have a large area of still avascular retina, releasing a lot of vascular endothelial growth factor agent. This is what drives the formation of the abnormal vessels that gives rise to retinopathy of prematurity. Now, we have various classifications of retinopathy of prematurity. On this slide again, I'm reminding all of us that the eye screening should be around 30 days of birth, not 3 months. So you have a premature retina. So you have an area that you don't have vessels, and this area you have vessels. And the vessels have to grow to cover this avascular retina, or the area that lacks vessels. But in retinopathy of prematurity, what happens is they start to grow abnormally. And the first thing you see is a line forming. So you have this line forming, which we call the demarcation line. Then this line becomes elevated, and we call it the ridge. Then over the ridge, you start seeing new vessels forming. Then that is stage 3 retinopathy of prematurity. Then you have lifting of the retina happening, which means there's retinal detachment. Now we have various stages of retinal detachment. If you have subtotal retinal detachment, is stage 4. If the retinal detachment does not involve the macula, then it's stage 4A. But if the retinal detachment involves the macula, which is the most sensitive part of our retina, then it's stage 4B. If there's total retinal detachment, then there's stage 5 retinopathy of prematurity. My first slide showed a baby I told you who had a white pupil that some may even mistaken it for cataract. This is a baby with stage 5 retinopathy of prematurity. Now, there's a standard classification for retinopathy of prematurity. I have shown it in the pictograph. So I'm going to show you some fundus photographs showing the various stages based on the international classification of retinopathy of prematurity. So you have, this is the optic disc, and then you have blood vessels. These blood vessels are abnormal because they are sort of wavy or tortuous. Now you have an area that you don't have vessels, so it's an avascular retina. And you have this area of vascularized retina. There is this white line, and that's stage 1 retinopathy of prematurity. It is called the demarcation line. Then this white line becomes thickened to form a 3-dimensional structure, and that is called the ridge. Then you have new vessels now forming on the ridge. So the ridge, the color changes from white now to pink because of the growth of new vessels, and that is stage 3. Now, at this stage, you have a retinal detachment with a fold of retina across the macula. and that is stage 4B. And then finally, you have total retinal detachment happening. Now, in terms of the extent of retinal involvement by the retinopathy of prematurity, it is based on the clock hours. I will not bore you with any details of that. Now, this is a fundus photograph of a normal retina showing the veins and the arteries. Now, you have here, the arteries are quite straight here. The darker vessels are the veins, so you have your veins. Now look at how tortuous the arteries are. These are babies who are at very high risk of progression of the retinopathy of prematurity leading to retinal detachment. And so when you see arteriolar tortuosity in at least 2 quadrants of the retina, then we say there's a plus disease. Sometimes the vessel development is just around the optic disc, as you can see here, which we call zone 1. So the retina is divided into 3 zones. We have zone 1, zone 2, and the peripheral one, zone 3. So if you have retinopathy of prematurity in zone 1, that is also a pointer that this child would rapidly develop retinal detachment within days. So we call it aggressive retinopathy of prematurity. So in terms of treatment, the mainstay of treatment of the severe form of retinopathy of prematurity where there is no retinal detachment is with laser photocoagulation. Now, we do know that vascular endothelial growth factors are the ones that promote the development of these new vessels, leading to the retinopathy of prematurity. And so people have resort to the use of antivascular endothelial growth factors to treat retinopathy of prematurity, where it is up to stage 3, but there is no retinal detachment. Once there's retinal detachment, we say it's either stage 4 or stage 5, as I described previously. So for those who qualify to be treated with laser, we have certain descriptions. All of them are captured as type 1 retinopathy of prematurity. Now, apart from retinopathy of prematurity, preterm babies also develop other eye problems that it's important that even they are not even within the criteria for screening. Once they are born preterm, they have eye problems that they need to be checked. For example, they can develop the lazy eye, which is amblyopia. They can have squint, otherwise referred to as strabismus. They can develop problems of not seeing well because they don't have the right pair of spectacles, that is refractive errors. And all these are things that you cannot detect unless you send these children to the eye clinic for evaluation. All right, so they can have other problems like cerebral visual impairment. These are babies where we examine and we don't find any problem with their eyeball, and yet they have poor vision. So in light of these problems, we set out to develop a program for screening. And our short-term goals as at 2018 was, first of all, we didn't know the incidence of retinopathy of prematurity in the country. We didn't know the risk factors. Yes, there was a retrospective study before that showed that there were babies who had some risk factors. And also, we do know that in the low-income countries or emerging middle-income countries, they have different set of conditions that these preterm babies go through. And so the screening criteria used in the developed world might not be suited for our environment. So we did a prospective study over a period of 7 months. That's from June 2018 to February 2019 in Kolebu Teaching Hospital, NICU. Now, before this time, we had not seen any type 1 retinopathy of prematurity baby at the eye clinic. What we see are babies with white people. We are not sure whether they have only cataract. Sometimes you do B scan and then the baby has retinal detachment. But once we started the screening, on the second day of our screening, we had 2 babies with type 1 retinopathy of prematurity. Then we realized that yes, the problem is really not far from us, but rather is within our facility. Now, this was the criteria we used: birth weight less than 2 kg, and then gestational age less than 37 weeks. Now, we screened 401 babies, and 55 of them had retinopathy of prematurity. Now, if you are using birth weight less than 1.5 kg, you are going to miss 5 of the babies. And then also for gestational age less than 32 weeks, you miss just 1 baby. In actual fact, this other baby had a gestational age at birth of 34 weeks, born to a mother with gestational diabetes. And then also the birth weight was 1.6 kg. But of the 55 babies that had retinopathy of prematurity, 7 of them had type 1 retinopathy of prematurity. Now, if nothing was done to this type 1, virtually all of them were going to get blind. So there were notable risk factors like birth weight less than 1.5 kg, male sex, confirmed sepsis, and then poor pupillary dilatation. So based on this information, we said we're going to use these 2 criteria for screening our babies. One is birth weight less than 1.6 kg or gestational age less than or equal to 34 weeks. And this should be done at or before 30 days of life. But the ROP screening is not done by just the eye specialist, the ophthalmologist. It is a process that involves the neonatologist, the neonatal nurse, ophthalmic nurses, and then the ophthalmologist. So to develop capacity for ROP screening in Kolebu Teaching Hospital, we had to send 3 people: a pediatric ophthalmologist, an ophthalmic nurse, and a NICU nurse to Aravin for training, and then also for them to get to see how retinopathy of prematurity is done in a large center that receives preterm babies for screening. So we even started the screening before we dispatched these 3 staff of Kolebu for training. The other thing is you need equipment for screening, and this is me doing ROP screening in Kolebu Teaching Hospital NICU, and this is the NICU nurse who was sent for training in India, were assisting me. Then once you detect those with retinopathy of prematurity, you need to treat. So this is a baby born at 28 weeks gestation and then birth weight of 1 kg, who developed retinopathy of prematurity, the type 1 at 6 weeks. Baby was unstable and was still on intranasal oxygen, and we had to do laser photocoagulation. So this is our laser machine we sent to the NICU to treat this baby. I mentioned that antivascular endothelial growth factor agents can also be used, although I'm a bit wary of it because of the experiences we are having in Kolebu with their use. So the standard of care in our setting probably is laser, but it is difficult doing laser for preterm babies because you are on your feet and laser in one eye can take up to an hour. Then you have to be on your feet again for about an hour to treat the other eye. But with these antivascular endothelial growth factor agents, you are seated and you give the injection. It takes about 5 minutes for the injection of the 2 eyes. But the problem is you need to monitor them. Unfortunately, these mothers do not come for review. Once they receive the injection, they are seen after 1 week. We don't see them again. And so there was an incident where a preterm baby developed obstructive hydrocephalus. And we saw after 6 months of injection, and this baby had recurrence of retinopathy of prematurity and now had stage 4B retinopathy of prematurity, meaning this baby had developed retinal detachment. Now, education is key because if the parents do not understand, they will say, why should they allow their tiny babies to have their eyes examined? And so this is an educative session of parents, and the education was led by the NICU nurse we sent out for training. There's also the need for awareness. I've had a presentation at the pediatrics of Greater Accra Regional Hospital, and then also our hospital, then also at our CPD of ophthalmologists and pediatricians in Accra, and then also our annual general meetings. So we develop certain materials to enhance education, but we still have challenges because one is we don't have adequate number of trained staff to do ROP screening in the country. And so retinopathy of prematurity screening as of now is restricted to only Kolebu Teaching Hospital. We receive referrals from Greater Accra Regional Hospital and other hospitals, but then they present late. Now, we need to document our findings. And in 2018, we didn't have a good fundus camera to do that. So you will see that the image wasn't good enough, and then you can see these tortuous vessels. Yeah, and also it didn't capture the peripheral retina. But this was a baby we took the pictures, and then we did laser. So these whitish wavy lines you are seeing are the laser marks that we did on the retina of this premature baby with type 1 retinopathy of prematurity. And the lasers are confluent, so they touch each other, the laser spots. Now we have a high quality fundus camera in Korle Bu Teaching Hospital that was donated to the Center for Research in Retinoblastoma. So we are now able to take quality pictures. But what we rather need are portable equipment that can be used to take pictures of preterm babies in their various NICUs across Greater Accra region and maybe beyond, where through telemedicine, I can be in Korle Bu and then just look at the images and see those who need treatment, and they can be sent over to Korle Bu for us to treat them. Unfortunately, we've not gotten there yet. So as at December 2021, we had screened 961 babies, and 250 of them had ROP. And out of the 250, 30 of them required treatment. Some received laser photocoagulation, and some received intravitreal bevacizumab, which is an antivascular endothelial growth factor agent. We received late referrals from other hospitals, and the number of babies with retinal detachment was increasing because as of 2019, we had just one baby with retinal detachment. Then 2020, we had 2, and the number went up to 8 in 2021. Now, this 8 is a bit abnormal and unusual, but it appears this is our condition. The pandemic we had, I think, had an effect on our screening, and so a lot more babies in 2020 going to 2021 had an advanced stage of retinopathy of prematurity. So I'll end my talk with the same slide that ROP affects our preterm babies who are still even under intensive care, and we need to see them by 30 days of life, and early detection is key to prevention of blindness in these preterm babies. Thank you very much for listening.
Thank you
Thank you
very
so
much,
much,
Dr.
Dr.
Iwonu.
Brian.
Thank you.
Yes, thank you so much, Dr. Brian. I think some of us have gotten the needed ophthalmology lessons today. Please, we are kindly reminded if you have any questions as the presentation is going on, please put it in the chat box so that once the presentations are done, you can read the questions out. We would invite the next presenter and then you can take it from there. So Star Gifty, please, back to you.
Thank you very much, Dr. Aluti. So we would have our next presentation, and this will be on brain complications of preterm. And to help us do this, there's no other person than my own head of department, who is a specialist pediatrician at the Whole Teaching Hospital and a part-time lecturer at the University of Health and Allied Sciences, School of Medicine, Department of Pediatrics. He's a member of both West African and Ghana College of Physicians and Surgeons, and holds a certificate in hospital administration and management system, GIMPA.
So what do you know?
He also holds some certificates in leadership and management in health, policy development, and advocacy for global health, both from the University of Washington. Is the acting head of department of the Pediatric and Child Health Sub-BMC at the Whole Teaching Hospital. Actively, he is involved in several community services. The recent one being the biannual pediatric specialist outreach visit, and also a member of the Pediatric Society of Ghana. His area of interest, of course, which is tied to the presentation about to be delivered, is pediatric neurology, metabolic disorders, and genetics. Kindly help me welcome Dr. Richard Daniel. Dr. Daniel, the floor is open. Thank you.
All right, thank you so much, Sister Gifty. That was a very kind words from you. So I'm doing brain complications of prematurity. So I'm doing brain complications of prematurity as I've been introduced. My name is Dr. Richard Bright Daniel. I have no... What's happening here? I have no conflict of interest to declare. I hope my slides are moving.
Yes, please.
All right, so this is the outline of the presentation. As you can see, we'll start from introduction and then end at conclusion. So hopefully I'll finish before it is 7 p.m. The objectives of my presentation will be to describe some brain complications of preterm, outline some preventive measures, and apply the knowledge that we acquire from these discussions during our counseling. And then for me, what I want us to remember is how we practice neuroprotection in various units where preterms receive care. So Dr. Saba was gracious to discuss some of this with us already. I want us to remember that 1 million out of the said 50 million preterms born annually, they die as a result of complications. And it is also important to know that there's rising burden of disability. And this is not just the physical and then the motor that we know, but there are concerns with visual and then hearing problems, learning disability, neurodevelopmental disabilities, especially amongst preterms. Now, that said, let's remember that there are also preterms who are wonders of the world, and they are found in science, in arts, and in music. Steve Wonder is a great example. Sir Newton is another. So it's not all sad when it comes to prematurity. The complications of prematurity can be tied down to these three basic things. Or the first one is immaturity, and they have immature growth. So the cell numbers are just not there. Now, these cells are also not specialized, so immature development, and then also immaturity in function. Now, mind you, the immediate complications and then late complications, and a lot of them have been said. Now, if you are thinking neck only affects the gut, it doesn't. There has been some studies that show what is described as the brain-gut axis. That means that the organisms that get into your gut determine how well your brain would even develop. So you can see that these preterms, most of their complications end up affecting the brain or the nervous system as well. So what is the scope of this complication? So I picked up this article from Leah et al. That talked about protecting the premature brain, and they talked about current evidence. And this was based on strategies for minimizing perinatal brain injury. Like I mentioned, the physical and the motor is well known. What about the cognitive impairments that these preterms suffer from? What is in the brain of this preterm? So just pardon me for some few minutes. We'll just go through this quickly. But this slide shows the cells that are in the brain. we all know the neurons, and it's what we all discuss. So the neurons are those that carry the instructions here and there. They are those that transmit information from one point to the other. Now, these neurons just don't stay alone. There are cells we call oligodendrocytes. What these cells do is that they form sheath around these neurons, what we describe as myelin. Why is myelin or myelinization important? It is important because it increases the transfer of information, or what people describe as the conduction of the information, about 100 times between these neurons. What these oligodendrocytes also do is that they also nourish the axons. These are the legs of the neurons. Another important cell in the brain is what we describe as astrocytes. Now, astrocytes are those that keep the microenvironment of the neurons intact. Here, we mean that they balance where glucose is heading towards. They maintain the metabolic environment of the neurons. And then they also help with what people describe as neural migration. Another cell which we should all know about is the microglia. So the microglia acts like the policemen in the brain. So they are in different stages. They can be resting, they can be primed, or they can be activated. And their work is to chop down anything that they deem foreign. Now, once you have this understanding about the brain, I want us to just take a look at what happens with brain development in the various milestones. Now, you can see that from the week 0, as you trans to week 13, that is the first trimester, best what you get is that some neurons are beginning to migrate, or they are beginning to move. And if you have a baby that is delivered in this first trimester, survival is almost 0%, because this child cannot maintain respiration, cannot suckle. There are a lot of things that this child may not be able to do. In the second trimester, up to week 28, some neuronal migration that has begun has advanced. Then now structures are beginning to form. And then now these neurons now want to start talking to each other. Sometimes this talking becomes haphazard, and then, of course, your policemen will now come and trim them, or what people describe as synaptic pruning. So up to week 28, this is what is happening. Now from week 28, that's when myelination happens. And the importance of this slide is to let us know that if you are born closer to week 28, a lot of this myelination doesn't happen, or the environment in which it should happen doesn't take place. And then you have problems of these preterms. And all this add up to the complications, or the brain complications of this preterm. Now, the causes of brain complications vary. The EOP here stands for encephalopathy of prematurity. One, like we've discussed, is immaturity. Once they are immature, there are a lot of problems that they have. The other thing is what we describe as hypoxia and ischemia, the low oxygenation to the brain, and then cut or loss of blood supply to the brain, or the developing brain. And of course, you would bear witness that the gutter in which the blood is flowing through, the blood vessels, they are very weak and they can break easily. So these children can have bleeds into their brain. They have problems with their coagulation. So they can either be forming a lot of clots or have a lot of bleeding tendencies. And then also the environment. And this is so important, because the maturation that is supposed to happen in the womb, it's not happening in the womb. It is happening outside. The sleep times of these preterms are being interrupted. We are doing 101 investigation on these preterms as and when. The NICU environment is not quiet. It's a lot of action, a lot of alarm beeping here and there. And we keep touching these preterms. So the environment also plays some key role in this preterms developing brain complication. And we can't live without mentioning almighty inflammation and then infection. The next slide just summarizes these causes, and some people have tried to group them to antenatal factors relating to preterm birth itself, and then postnatal factors. And all this ends up in injury to the preterm brain. Now, mind you, the oligodendrocytes, the pre-oligodendrocytes, they are very vulnerable and they die very easily. And once they die, myelination doesn't happen. Conduction of impulses from one neuron to another isn't optimal. And then this would manifest in the various problems that these preterms have. So this is what I try to talk about. Now you can see the other baby is still developing nicely. Myelination is going on. A mother may be playing some rock music to the baby. He's insulated from sunlight. Compare that to this other environment. You can see a lot of beeps, 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 a lot of lights, and then this child has oxygen, there are probes, and this child is in this container that can move. One time the head will be there. The child is not contained. Now, mind you, whilst you're in your mother's womb, the womb serves as some limit. You can't move forever. There are limitations. The womb kind of limits you. And all this helps in the maturation of these babies, their brain. And preterms don't have that luxury. I'm happy Dr. Bryman mentioned his presentation about retinopathy of prematurity. I remember this study so well because we were part of those who were getting some of the preterms to have this screening done. And if you don't take anything away, remember that oxygen is a drug and it has to be used judiciously. Now, there are some other common problems. I touched on the bleeds that can happen. One of them is the intraventricular hemorrhages that can happen. And it said that studies suggest that 30% of preterms, especially those who are less than 1.5 kg, will develop intraventricular hemorrhage. And 3% of these preterms, those below 1 kg, would develop leukomalacia. Now, severity of all these bleeds and leukomalacia is inversely proportional to the gestational age and weight. The more weight you have, the less likely that you have this complication. Now, there has been some grading. Of course, this is not for our consumption, but it is good you know, because when you send the request for transfontanal ultrasound and they tell you that the child has a grade 2 periventricular hemorrhage, what does it mean? Grade 3, what does it mean? Well, for you, what we can take up here is that the grade 1 and grade 2, the prognosis is good. This blood gets reabsorbed and then these children develop normally. The prognosis usually is good. However, if you are entering towards grade 4, mortality approaches almost 90%. So if you do the scan and they tell you that this child has a grade 4 intraventricular hemorrhage, then you know the counseling that you are going to do for this parent. Yeah, importantly, the presentation of intraventricular hemorrhage varies. The early presentations may include child whose vitals are not holding. So one time pulse is high, another time the pulse is low. This child has repeated movements in the eye. So these are early presentation. However, if you notice that preterm is having seizures, the fontanel, the diagonal thing atop the head is bulging or is full, or this child is posturing, the head is tilted up backwards, then you know that this child is in trouble. And mortality here is approaching 90%, like we mentioned. So complications, if you have bleeds into the brain, of course, the brain doesn't have the cells to grow or develop. So there's reduced brain volume. These children may develop hydrocephalus and they may develop periventricular leukomalacia. And this is how periventricular leukomalacia looks like. It looks like cheese or cheese that has been eaten through. And why does this happen? It's because the policemen are activated and the astrocytes also get degenerated. So the policeman just goes to punch holes in the brain, and this is what you are going to see. These are the initial symptoms that you would see. Child may be apneic, the blood the pulse may be low, this preterm may be irritable, and this preterm may have decreased tone in the lower limb. So the tone here will be decreased in the lower limb. And you can understand this if you look at the pathophysiology of periventricular leukomalacia. Long term, these children will develop spastic cerebral palsy. They have problems with their vision, and then their cognition is also impaired. And of course, it is also associated with seizures. It is recommended that if you have any preterm between the corrected gestational ages of 36 to 40 weeks, at least they should have a transfontanal ultrasound to look out for periventricular leukomalacia. And then also, if you have any of the signs and symptoms discussed in the intraventricular hemorrhage, this should be done as well. At least if you have any preterm below 1.6 kg, a transfrontal ultrasound should be done or is mandatory. Now, we've mentioned some babies who are at risk or preterms who are at risk. The gestational age, which we've discussed, it is said that you have a lot of male preterms suffering a lot of the bleeds into the brain. So especially if you have a male preterm below 1.5, absolutely, you should do a transfontanal ultrasound. There's a history of antepartum bleed in the mother. Again, these babies, you need to at least screen, and they are at risk of developing complications in the brain. The mode of delivery, preterm that are said to be delivered through cesarean section, are said, or literature suggests that they have less of the complications, brain complications of prematurity. If the child or the preterm is showing you clinical manifestations very early after birth, usually the prognosis is bad. How do you manage brain complications in preterm? Labs, including full blood counts, at least you look at the hemoglobin level, which is so important. Again, they will need to look at the clotting profile, blood sugar. Now, for the preterm, we prefer a cutoff of 3.0 millimole per liter. So anything below that, you need to actively manage hypoglycemia. Yes, the blood urea electrolytes and creatinine should also be done as well. A lot of us don't have access to arterial blood gases, but the standard is that this is something that we should do for these preterms. As states of metabolic acidosis could have some impairment in their brain function. We can't belittle the point about transfontanal ultrasound. If you want to do any higher imaging, MRI is preferred to head CT because of the radiations from CT scans. So what are some of the principles of management brain complications in preterm? As usual, the general measures: make sure the airway is patent, this preterm is breathing, and then the circulation is intact. You can't be working at a center where you are taking care of preterms, for that matter, neonates, without knowing how to do simple bag and mask ventilation. And it's something that if you know you don't know, you should at least ask for some training in that regard. Actively managing or correcting fluid and electrolyte disturbance is also key in managing brain complications in preterm. You also need to monitor the head circumference, and there are charts that are available so that you could follow up on whether the preterm's head is growing faster or the growth has been stopped. And all these are concerning for neurological outcome for this preterm. You can't use the normal charts that we use for 10 babies. So preterms have a special chart which we can all download and then use for these preterms. And of course, you need to manage concurrent conditions. Minimal handling, like I mentioned, this cannot be overemphasized. And then screening, like we said. The environment control, of course, the medications that we give. Now, mind you, these preterms they have immaturity, like we mentioned, and medications that are handled by the kidney and then the liver. Of course, you should use the BNF, for example, so that your dosing will be appropriate for the particular gestational age for these preterms. Dr. Saba mentioned kangaroo care already. Some of these preterms, if they develop hydrocephalus, may require shunting, and especially by age 2 years, most of them would require shunting. What are the outcomes of these brain complications? Like I mentioned, there has been reported increased risk for psychiatric disorders in preterms, autism spectrum disorder, attention deficit hyperactive disorder, and even mood disorders in preterms that have survived. And most of them they have lower educational attainment. So again, it's because of the little things that we could have done to save them that we didn't do. And some of them may have lower educational attainment. They may have concerns or delays in speech and language development. Then they are social and then emotional. They have a lot of emotional ability. And then the cognition, like that we mentioned. Of course, the physical and then the motor disorders, those ones are very noticeable. And a lot of us easily pick this up. Now, what can we do? Now, we'll be sharing this particular paper with those who would put their email addresses up. It's about the neonatal integrative developmental care model. And this is a seven-step or a 7 care model. It looks at the healing environment. How do we touch these preterms? The sound around the preterms, especially when they are with us. Lighting at our various places where we take care of these preterms. How are we partnering with the families? Does the parent, do they have access to this preterm? Are we optimizing nutrition? And as Dr. Saba mentioned, these are so key to survival of this preterm and then they thriving as well. How are we positioning and then handling this preterm? Do we leave their heads to lie on one side for a long time? Now, mind you, if your head, for example, is lying on just one side, development and growth on that particular side becomes impaired. And so most often, some people say that when they see a preterm, they can pick them up easily because they have more of a small flat head on both sides. And this should not be the story that we should be telling. Are we safeguarding the sleep of these preterms? While they are in their mother's room, they have a lot of sleep time. And the only time they wake is when the mother will tell you that the baby has kicked. However, when they get to our NICU, we don't protect their sleep time. The baby now closes his eyes to sleep and then, hey, we are taking full blood count. The baby does this. Oh, now we forgot to take BU and creatinine. We forgot to do this. And we have to weigh this baby. So all this disrupts the sleep of the preterm and doesn't help with them having good maturation and then development of their brain. And this ties in nicely with minimizing stress and pain for this preterm and then protecting the skin for this preterm. So like I mentioned, once you share your email with us, we'll try and get this particular document to all of us. The good thing about these 7 steps is that it doesn't mention any high equipment. And this ties to our theme, small actions, big impact. So of course, the long-term follow-up, you need pediatricians. You can see a very tall list. It's not exhaustive. You can see the ETC there. That means that other people may come in. Remember that these preterms is not just the brain that is affected. Their kidneys have problems. They sometimes have problems with their hearts. So we need all these people for effective follow-up for this preterm. Let's remember what Dr. Breimer said, that it is 30 days after birth. This preterm should at least have a screening ophthalmoscopy done. How do we prevent brain complications? Now, these are known. I mean, one, we have to prevent the preterm birth in its entirety. There are factors that we can modify. Mothers that have diabetes, hypertension, we should be able to manage those chronic diseases well. The preventing the 3 delays that we are all familiar with, minimizing handling of these preterms is also important. And then prompt identification and then treatment of infections, both ascending infection and then the preterm that has picked up a bug at our NICU. So we should be able to modify these risk factors to the benefit of the preterm. We cannot overemphasize administration of maternal corticosteroids. Delayed cord cutting is said to stabilize the BP of these preterms. And then this also helps with what the books describe as cerebral autoregulation. All it means is that now the brain would have its fill of the blood, so that at least these preterms can have a good grounds to start off with. Magnesium sulfate. So we all know, I mean, there have been several studies, mag sulfate given to our mothers who come in with convulsions, with eclampsia and then pre-eclampsia. So this was actually an add-on effect of magnesium sulfate that was picked up. It is noticed that mothers who receive mag sulfate, not primarily for protecting the brain, however, it was realized that those babies that have their mothers receiving mag sulfate, they had less of brain complications compared to mothers who probably had hypertension, never had any convulsion, and never received mag sulfate. So it's one of the things that has been the green light has been given for its use, especially to prevent brain complications of prematurity. Surfactant therapy, very expensive. The primary thing is to help relieve respiratory distress syndrome. But now, mind you, hypoxia, low carbon dioxide, all those things also affect the microenvironment of the brain. So once you are able to help these children have very good saturations, the brain complications also become less. Now, there are some promising scientific findings, the use of erythropoietin. There are some things about hormonal use, progesterone, and then estradiol. Let me emphasize that these are in animal models, and it's not been passed for use in humans. The progesterone and then the estradiol is in animal models and has not been passed for use in humans. And then we mentioned the stem cell. I mean, we don't do this in Ghana anyway, but it's something that we should know, and we may get caught up in it soon. So this was one of the studies that I put up. Again, this was done in neonatal rats. It looked at neuronal cell damage in the cerebral cortex or in the brain, and then hippocampus of the neonatal rats following hypoxia and then ischemic events in this. Now, there were two groups. One of them were treated with estradiol. The other group was treated with normal saline. And then you can see the neuronal cell damage was significantly reduced in both the cerebral cortex and then the hippocampus for those who received estradiol compared to those that received normal saline. So this is also showing some promise. But let me again add that this is studies in animal groups and has not been passed for use in humans. So in conclusion, brain complications of prematurity can have myriad causes. And what can we do to prevent? And these are to prevent it. And these are some of the things that I tried to touch on in this presentation. And we've tried to lay some emphasis on modifiable factors and how we can offer effective care. Appropriate counseling is always key. Now, this would help, as it were, give all of us a fair ground. So we all would have better expectations of each other. The parents know what they are expecting. You, the staff, you also know what you are also expecting. Now, all what I've been trying to communicate is that we should not just look at these preterms surviving, but we should look at them thriving. So let's remember that as we have retinopathy of prematurity, we also have what? Encephalopathy of prematurity. And together with our small actions, we will have big impacts in these preterms. So ladies and gentlemen, I'll bring my presentation to an end, and then, as the MC said, if there are any questions, we'll pick them at the end of the presentation. Thank you, and over.
Thank you very much, Dr. Bryce Daju, for this presentation. By now, all participants, no matter your cadre, I'm very sure everybody is speaking what he or she has to do, or the role we have to play together to help these preterms survive and thrive with our little action, making big impact. We will continue to have our last presentation for the day, and I would hand over to my colleague, Dr. Alote, to introduce us our last presenter for the session. Over to you, Dr. Alusi.
Yes, thank you, Sir Gifty. Yes, so I think at this point we have given birth to our preterm. We have gone through learning about retinopathy of prematurity and then encephalopathy of prematurity. Now we have discharged our preterm and we want to know what we can do in our small ways to make sure that we have the best outcome for such babies. So our last presentation is going to be on post-discharge care for preterm babies. And this presentation is going to be given by Dr. Selom Chakasu. So I'll just give a brief introduction to our speaker. So Dr. Chakasu is a pediatric specialist with the Ho Teaching Hospital and a part-time lecturer with the University of Health and Allied Health Sciences, which is UHAS. He's a member of the Ghana College of Physicians and Surgeons and Pediatric Society of Ghana. He is author of Child Doctor Series, a health advocate and volunteer with Operation Smile. So we'll hand over the reins to Dr. Chakasu to take us on this topic. Thank you.
Right. Good evening once again, and thank you, Felix, for the introduction. So I'll quickly go through, since time is not outside, and in fact, a lot of the things I'll be talking about have been mentioned in previous presentations. So we are talking about post-discharge care of preterm babies. And all right, so just a disclaimer, majority of the content of this presentation is not my work. So I therefore duly acknowledge Dr. Daina Panga for providing this material for the purpose of education. This will be our learning objectives to determine if a preterm infant is ready for discharge, identify the major aspects of follow-up care, and then to identify preterm infants not growing optimally and how to intervene accordingly. So this will be the outline of my presentation. So just a short introduction, and this is an excerpt from an article I saw online by the Canadian Pediatric Society. The topic is discharge planning of a preterm infant. So it says the preterm infant's journey may begin well before the admission to the NICU, with a prolonged hospital admission for the mother, frequent perinatal ultrasounds, and close surveillance of the pregnancy. In some cases, the delivery of a preterm infant comes without warning. Regardless of scenario, admission to the NICU is a stressful and anxiety-provoking experience. Every infant admitted to the NICU experiences a unique hospital course that is often commensurate with their gestational age, with the length of NICU admission being inversely correlated. Complications such as sepsis, necrotizing enterocolitis can individually or in combination contribute to the length of stay. After recovery, the safe discharge of a preterm infant at a minimum is dependent on the attainment of their physiological maturity. So what are the primary goals? Before discharging a preterm, there are certain things you want to achieve. The medical readiness of the preterm, the family, how ready is the family to receive baby at home? And then the home itself, how well prepared is the home for the preterm baby? And then what routine discharge screening plan has been set out for the family? And then finally, strategic follow-up plan in helping that preterm survive. So for medical readiness, quite a lot has been mentioned in our first presentation. We want to ensure our preterm baby is able to control their body temperature, their maturity of their respiratory efforts. You know, the complications such as respiratory distress syndrome is very high in preterms, especially those with very low gestational age. And you want to ensure you're able to wean them off oxygen, they're able to respire spontaneously with less effort before they are discharged home. Then also maturity when it comes to their feeding. For most preterms, they have challenge with suckling. And so you want to be able to achieve that before sending them home to avoid certain complications such as aspiration. And then demonstrate a consistent pattern of appropriate weight gain, which we'll look at down the presentation. And then finally, able to sleep with the head off the bed flat in a supine position without compromising the infant's health and safety. So for family and home readiness, these are a few questions I've put together that you want to be able to answer appropriately with the mother. So you should have a counseling session, not just once, several times. You meet with them, explain the condition of the preterm baby, their problems that they can have. And then before they are discharged home, you want the family to be able to assure you that they can handle this baby when they get home. So these are a few questions you should look at. The first one is family psychologically ready to receive preterm baby? 2, is the home prepared to receive the baby? Has the necessary education been done about the baby's condition and the value of consistent follow-up post-discharge? Just before we started this exercise, the interaction with my colleagues, we've noticed that there's this challenge we face in our NICU clinics where we're having less and lesser number of mothers bringing their preterm babies for follow-up. And this is very important, even after educating them extensively. So we have to find better means, ways of getting them to come, which we can talk about in this forum. Then the last question is, have they understood the extra care they have to provide for the baby, such as kangaroo care, complementary feeding, and how to detect danger signs so as to report early to the hospital? Once these questions are appropriately answered, I think you are closer to discharging that baby home. The next thing is routine discharge screening. So we've heard very clearly the importance of ophthalmologic screening, how it should start 30 days, right from birth up to 30 days, the screening should have started. And that was the earliest time you should be able to pick retinopathy of prematurity. Other problems that the babies can have is hearing. So here, screening for their hearing is important. In developed countries, they even screen them for metabolic and genetic disorders, screening them for intraventricular hemorrhage, as rightly said by our previous presenter, the importance of transfontanal ultrasound. And then in specific cases, full blood count or alkaline phosphatase is very necessary. There's an author and child cartoonist who said, a person's a person, no matter how small. So our preterms are just as important as the adults that we see walking around. All right, so for the post-discharge follow-up of preterm infants, these are some 5 pillars that I've outlined. The first one has to do with growth and nutrition. Second is immunization. Third, psychological issues and family. Screening exercises you'll be doing post-discharge, and then daycare. All right, so for growth monitoring, the overall goal is to achieve the body composition and rate of growth of a normal fetus or infant of the same post-menstrual age during the first entire year of life. And the parameters you'll be looking at is the weight of the baby, the length, and then the head circumference. You also want to ensure that the frequency of visits is something that you look at. For post-discharge, immediate post-discharge of a preterm, you want to do it at least twice a week, looking at these various parameters. Once you are confident that the baby is developing or growing well, then it can be extended to once monthly, to once in 3 months, all depending on what the parameters tell you. So if you have a child, even if after the first 1 month post-discharge, still weight is not increasing, then the monitoring must be more. All right, and then setting aside a special day for reviewing of the clinics, of the preterms, I mean. All right, so for growth monitoring, for weight, correction for gestational age should be made for monitoring the weight through to 24 months of age. So you want to be able to compare the preterm's actual weight with the preterm's age. So we use the corrected age. If you use the chronological age, and with the charts that I'll share with you, it will give you a false impression that baby might not be developing appropriately. So you're supposed to use the corrected gestational age. So that's for the weight, and then for stature through to 40 months of age, and then for head circumference up to 18 months of age. All right, so these are a few charts that we use on our wards. Commonly, we use the Fenton growth chart, but the other ones, such as the Olsen and Bertino growth charts, and then we have the WHO growth charts as well. So these are the diagrams just to explain them. Okay. All right, so for the weight, what are you expecting? Every time baby comes to the clinic, whether twice a week or once in 3 weeks or whatever, you are expecting that the weight gain should be a range of 15 to 20 grams per day. If baby is breastfeeding appropriately, getting the top-up feeds, as was explained in the first presentation, you are expecting that this is the weight that you should see in the preterm. All right. And then for the length, we're expecting about 1 centimeters per week. And then head circumference, 0.7 centimeters per week. All right. So what factors can we look at to ensure appropriate growth and development? One factor has to do with adequate feeding. So for the type and the volume of feeds, the human milk is the best. But for preterm, sometimes we have to fortify the human milk where some coconut milk, coconut oil is added, and some other products are added to the human milk just to help with the weight gain. Formula is also available, but it's more of a secondary choice. And then the frequency of feeding. Usually we will counsel our mothers that they should try to feed baby as frequently as possible. If anything at all, at least every three hours, they should feed the baby. And you want to encourage them not to just breastfeed, but they should also give top-up feeds. That's the cup feeding that was explained. So not just breastfeeding, but breastfeed with top-up feeds. And the volume should be calculated depending on the caloric and then the protein requirements of the preterm. Then adequate supplementation. So we all know there are certain complications that can arise. So we try to ensure our preterms are well supplemented. And this is a list of vitamins and minerals that are important. Iron, especially because of anemia of prematurity. And I must say from researches that one of the commonest complications you see in the post-discharge clinic is anemia of prematurity. And so to avoid frequent blood transfusion of our preterms and its adverse reactions, we want to supplement them with iron. And then we have vitamin D, folic acid, zinc, calcium, and phosphorus, which can be found in our multivitamin syrups that are available on the market. I won't mention any name, any brand name. Just find one which contains all this in their right amounts. Next factor is kangaroo care, which has been explained. So you want to encourage the parents or guardians even after they've gone home. So they were practicing it at the NICU or at the baby's unit, but even when they go home, they're supposed to continue providing kangaroo care for the preterm because it improves growth and the weight of the baby, it improves his baby's immunity, their sleep, and then temperature control. So kangaroo care is very, very important and should be advocated for. So monitoring growth. Preterm infants are at risk of inadequate growth due to their increased caloric and nutrient requirements and greater weight gain before reaching the term is equivalent, is associated with improved neurodevelopmental outcome. If growth is inappropriate, the infant's nutrition should be evaluated for corrective measures. And that's a multidisciplinary approach, so not just the pediatrician, but the pediatric nurse, specialists, our dietitians should be involved. Sometimes it could be due to feeding difficulties. So baby has to be well assessed to find out why baby is not developing or gaining weight appropriately. All right, so the next post-discharge plan we should also do is immunization. So preterm infants are at increased risk for vaccine preventable infections. Immunization in the preterm infant results in a protective antibody response. And therefore, as a result, the American Academy of Pediatrics generally recommends that medically stable preterm infants should receive full immunization based on their chronological age, consistent with the schedule and those recommended for full-term infants. How is the administration done? In preterm infants, the site for administering intramuscular vaccines is the anterolateral thigh. Bear in mind, these are preterm, so their fat layer is very small or is thin. So you want to be careful the length of the needle you are piercing through to administer your vaccines. And then the screening exercises that should be conducted throughout the post-discharge. Hearing is very key. Preterms are at risk of sensorineural hearing loss, and therefore they have to be sent to our auditory units for them to be assessed for hearing impairments, as well as vision, which has been clearly stated by our second presenter. Also, we monitor their neurodevelopment. We want to make sure our preterms are developing appropriately. And if for some reason there's a delay, then the necessary interventions have to be done. All right, then psychosocial issues and family. So even right from NICU, you are going to be dealing with psychosocial issues. Parents are anxious, are scared how to even hold the baby in their arms, but they should be encouraged, they should be taught how to do all these things. And even throughout the post-discharge period, we should keep encouraging our mothers especially and the family on how to care for the preterm. Finally, the daycare is key in post-discharge. Before sending the preterm to a daycare, parents should make sure that the patient is stable on room air or oxygen and feeding is on routine schedule. A licensed daycare personnel should be trained in cardiopulmonary resuscitation because of the risk of respiratory distress and apnea. So patients should be kept out of daycare if they are at high risk of infection, especially if they are being discharged during the cold season. So we come to the end of post-discharge care plan for preterm. So in summary, prematurity remains an important global burden with significant long-term morbidity and mortality. Comprehensive discharge and follow-up planning is necessary to improve survival with no or minimal impairments. Even though healthcare professionals are few, better management of preterm is possible. Thank you.
Thank you so much, Dr. Trakasu, for such an insightful presentation. I think we've gotten to a stage where we will now open the floor to audience members who have questions. We have some questions in our chat box that we would read for our presenters to kindly address for us. So we'll start with Dr. Ibrahima. We have an audience member, Mr. Gleason Selassie, who would like to know, as a NICU nurse, at what point he can detect or know that a preterm needs to be examined for retinopathy of prematurity? Or is it that every single preterm needs to be examined within the 30 days? So if Dr. Ibrahima can please address that for us.
Whilst we wait on Dr. Brima to answer this question, kindly, this is the chat session. There is a link shared for assessment. Kindly fill in the assessment form and then add your email so that the presentation can be mailed to you. Thank you.
Yes. I think we don't have Dr. Brima yet. Dr. Daniel, please, we have a question. So how do we square off the plasticity of preterms and then their ability to develop encephalopathy or prematurity?
Sorry,
Dr.
I
Daniel,
missed
please.
the question.
Yeah, so the question is about how do we square off the plasticity of newborns and their ability to develop encephalopathy or prematurity. And we are expecting that once newborns have very plastic brains, the ability to heal from any brain insult should be higher. So how do we square that disparity?
Yes, so that analogy holds true for the term baby, because the term babies doesn't have the pre-oligodendrocyte may have machine. Some analogy would hold very true for the term baby. What you can do for the preterm is that we make that time, the time, especially those that are born between the 28 to 37 completed weeks. Remember that the third trimester is when a lot of the synapses, the neurons joining, now my new myelin now forming, the neurons now doing their migration. That is when it happens. And during that time, this preterm, all the preterm needs is the sleep, a good, quiet, and relatively dark environment, the tender handling of the mother. And they said that those that even are able to do up to 6 hours of kangaroo care or are giving care in between their mother's breast for just 6 hours, even in a week, it said that their brain growth and development is 30% higher than those who don't have any form of kangaroo care. So those little small actions are what we are discussing and then are advocating for. And then the first question, the first person who asked the question, like Dr. Brima mentioned, every preterm, the gold standard is that within the first 30 days of that preterm's life, especially those who are born gestational age less than gestational age or their gestational age weight, which is below 1.6 kilogram, that preterm should have his or her eye screened.
Okay, thank you. Dr. Daniel, so I think I don't know if I'm speaking on behalf of most of us. I think we are all in a sentence where it's difficult to do the retinopathy of prematurity screening. So I think what Salasi was trying to find out is there any pointers that he as a NICU nurse would be able to see and then tell, oh, maybe we may give priority because where we are sending the child to maybe Kolabo to get a screening is a bit impossible. So is there any particular things that you would see that they would bring their mind to, oh, maybe this baby needs special screening, so let's move that baby to Kolabo to get it done?
Okay. So not what I gathered from Dr. Brimer's presentation though, but I mean, Dr. Trakasu was just sharing with us a 2-year-old who preterm probably between 30, 32 weeks, who is currently blind. And of course, while this baby was going, I mean, we never did any check for that baby. So that baby has, for example, lost his or her sight. Now, mind you, like Dr. Brima mentioned, after 6 weeks, there's complete retinal detachment. So as a NICU nurse, the asterisk babies are those whose weights are below 1.6 kg. If we have any of those babies, at least we should have screening done done for them. But again, I mean, we'll relay this question to Dr. Brimer and then fast forward answers to all of us. Thank you.
Thank you. Thank you.
Thank you very much, Dr. Daniel. I think the other question asked, again, we would have to ask Dr. Imoro. It's as to the cost of laser therapy. Or if someone has a fair idea on the panel, how much it costs. Okay, so again, using the chat or the comment section, there's a link being shared for evaluation of the CPD that we are just about to end. Kindly fill the form.
Yes.
And at the tail end, indicate your email address so that the presentation can be mailed to you. Dr. Daniel, I hear you.
Yes. So, please, I have another question. This time directed to Dr. Saba. So, someone wants to find out. We have mothers who are always worried that, oh, I have a preterm, and this preterm, I'm worried about giving formula because they are worried that baby may develop complications. How do we square that? So we're talking about nutrition and preterms, and how do we help talk to our mothers that okay, breast formula use is safe in preterms.
Okay, thank you, Dr. Alute. So, as much as you want breast milk, you want formula to be so close to our, let me say, the manufacturer say it is so close to breast milk. Breast milk is still the best for every newborn, whether it's a term or a preterm newborn. Now, the issue with the preterm is that there's the high risk of developing necrotizing enterocolitis, especially if you introduce formula feeds. So for preterms, we encourage all mothers. It can be difficult, especially when the mother is stressed. She spent most of our preterms will spend the first few days with no feeding, and the mother is stressed. Her body has not been primed to start lactation because she didn't go through regular labor. She's probably sleeping on the ground in some corner in the hospital. She's not eating well. Yesterday, I was reading I don't know, a guide written by a mother whose two children had ended up at NICU at one point or the other. One was for perinatal asphyxia and the other one was for prematurity. And she kept insisting in this guide that the mother should eat, because by the time the doctors will tell you they are ready to feed the child, if you are not eating, you'll be too stressed up that you will not be able to produce any milk for them to use for the child. So, Dr. Alute, to answer your question, as much as possible, get the mother to rest. She should feed well. She should get family support so that they're running errands to go and chase lab results, take samples to the lab, with the back and forth. Someone else is doing that so she can rest, so she can be able to produce enough breast milk. And as much as breast milk, as much as formula is close to breast milk is still the best for this newborn. I hope that answers
All
your
right. Thank you, Doctor. Yes, please, it does. Thank you. Mr. Gipsy, please, do you have any questions from your end?
No, please.
So, all right. I don't think we have any more. I think aside the questions that were directed to Dr. Brimer, which will get answers and then relate to our members, there isn't any more questions. Again, we are reminding ourselves of our theme for the Prematurity Month. We want to make sure that we are, in our individual ways, are making small actions that would have big impacts in the lives of our preterms. I don't think we have any further questions. So we would kindly ask our chairperson if she's still on, if she has any closing remarks for us.
Hello.
Yes.
Yes.
Thank you all for joining us for this CPD. We hope you enjoyed it as much as we enjoyed putting it together. The fact that an average of 130 medical professionals see personal and professional schedule is evidence that we're all willing to make a difference in the life of our dear preterms. These conversations about prematurity serve as refresher courses and updates that help us spot and manage not just the early complications like necrotizing neuropathy of prematurity, bronchopulmonary dysplasia, and intravascular hemorrhage, ventricular hemorrhage, but also to spot and manage late complications like neurodevelopmental vision problems, growth problems, lung diseases, and other issues that these children might face. Additionally, it's our approach to management, particularly ones that are applicable to our sociocultural context, despite all the challenges that we face in our various units. Thank you, Dr. Adams, for being the Thank you, Dr. Barima Imoro, for your insightful presentation on retinopathy of prematurity and updating us on the current progress in Kolebu Teaching Hospital. Dr. Bright Daniel, thank you so much for bringing to the fore of our brain the brain complications. And to Dr. Trakasu, thank you for the post-discharge follow-up presentation. Thank you all for your patience, and I wish you all a very good evening.
Thank you for agreeing to chair this session for us, and thank you for your contribution as well. At this point, I think Dr. Alote, we will bring our CPD to a close. We want to appreciate each and every one that has taken some time off their busy schedules to join us, have a successful CPD session. Thank you very much. See you again next time.
Thank
Until
you.
then, it's a goodbye.
Bye-bye.